Thank you very much for having me here. It really is an honour to be here. And I am going to talk about just things around equity and rights. Many of you have heard some of this before. But the first thing, and people have said it already, like just look at the people that are here. There's a load of people here talking about these sorts of issues. It's just great. This is a new, it's not new anymore, but it's a growing new body that anyone new that wants to join needs to be encouraged to join as well. So this is the Professor John Keaveney Memorial Lecture. We've had these at every forum conference since the forum started having conferences. So as Rory said, John was the Professor of International Health in Trinity, and he was a hugely influential figure who did things for health in many parts of the world, but also did things for health here. He was concerned around, as Rory said, about issues about poverty and about the poorest. He has this, the world's biggest killer and the greatest cause of ill health and suffering across the globe is extreme poverty. The effects of poverty and health are never more clearly expressed than in poor communities in the developing world, and the scale and persistence of these problems is a blunt reminder of an international obligation ignored. So I had been meeting John. I moved back to Ireland in 2001, and I had been meeting John at meetings in Irish Aid around HIV and around product development partnerships. There was a discussion this morning around medicines for malaria venture and the AIDS vaccine and malaria vaccine. Like Irish Aid was considering funding those things back at that time. And part of our conversation was about education around global health and like what should be being done. When I moved back to Galway, I had students asking me to come and talk about working in developing countries primarily. So with a colleague, we set up a course on Thursday evenings at 5 o'clock. And we said we'd offer a series of 7 lectures or 10 lectures, and we had 70% of students turning up. So that was just, it showed us there was something that people wanted to do more of. So we talked about we need to focus this in some sort of a way. So John, I'd gone to meet him specifically around, could we do something about curriculum? Could we do something that we could introduce into medical and nursing schools in Ireland? And to wider people involved in issues related to health as well. And had a series of these meetings, and then suddenly I got a text or a phone call from Vincent O'Neill in Irish Aid saying that John had died. It was really, really shocking and must have been devastating for his family. So then at his funeral, Rory's mentioned his funeral, Vincent O'Neill from Irish Aid said, what are you going to do about this? You have to do something more with this. So he said, I'll give you, if you need funding to organise a meeting, have a meeting. So we had a meeting, which, going through my notes, was 16 years ago today. We had a meeting in Galway. And we were aware that in UCL in London, a group called MedAct, who are linked into the People's Health Movement that I'll talk about in a minute, were introducing curriculum around global health. So we got them to come and talk about what we could do. We had a name. The name is changing and moving as things go on. We had our first formal launch then in Trinity the following year. And we set out, the aim was to look at things around research, education and advocacy on global health issues. We had language about no borders, and I'm moving now across a no border that might become a border. We talked about the links between health, poverty, inequity, sustainable development, education, human rights and gender issues. The issues are not changing that much, as we'll see. But some things have changed. So John influenced this hugely. And as I said, we've had the Keaveney lecture at each conference since then. And I know Trinity have a Keaveney medal in his honour on the Masters in Global Health as well. So some things have happened around wider education. And there's, Irish Aid funds a lot of development education in primary schools and secondary schools, little bit in higher education, and there's potentially scope for much more because students want this stuff. Young people want this. Look at all the young people that are here. People see the world in an interconnected way. In the UK, they've actually identified what the global health capabilities that any health professional should be graduating with. So this is core content that's now recommended in the curriculum for people studying who are going to come out with any kind of a health qualification. So there is a way to start looking at some of these issues. And you see that diversity, rights, ethics, determinants, there's epidemiology and governance, there's health systems and health services, there's health professionals, there's a whole lot of things that all link into many other parts of health and healthcare. And as was mentioned this morning, like the SDGs are informing what we do. There's actually even a guideline for universities to get SDGs underway, and increasingly universities are starting to report their activities linked into them. So so that's 16 years that we've been thinking about what we could do with these sorts of activities. And you're probably all aware of these sorts of messages, that the world is improving. There's a great book by Hans Rosling from Gapminder about factfulness and about the facts and the evidence that things are getting better. Life expectancy is increasing in many countries. Child mortality is declining. At the talk about malaria this morning, I had been a registrar in Crumlin, looking after sick children in Crumlin, and I ended up in a hospital in Zambia, say a week later, where 3 children died the first night of completely preventable things, and this just wrecked my head. So that's still happening, even though there aren't as many people dying from malaria. We're seeing that the numbers of people in extreme poverty is declining. I'm sure many of you know this, our world and data, but have you seen some of the critiques of the way this information is being presented to us and who's funding it? Like, it raises questions for us. I mean, this measure of who's in extreme poverty is based on the idea that $1.90 is the measure of extreme poverty. At the same time, the FAO is telling us that there's hundreds of millions of people hungry and that there's billions of people who are have micronutrient deficiencies. So, if they're not extremely poor, what is the measure for poverty? So, I mean, this poverty line, there's people saying it should be $5, it should be $7, and there's different ways of looking at this. Jim Clarkin mentioned this morning on inequality and on Oxfam's great work around global inequality, and the small number of people that are controlling, who are incredibly wealthy, who are controlling information and controlling power. And when you go for some of those other lines, those poverty lines, you see that actually the number of people and the number of people who are extremely poor hasn't changed. And the MDG was about the number, the SDG is about the proportion. So we need to think about how these things are actually being presented, because the gap between the rich and the poor and between the us and the them in every country, as well as from one part of the world to another, is increasing. So we need to think about the SDGs in this wider way, and we've probably all seen this, the SDGs come into multiple ways. We need to talk about the poor people. Who are the extremely poor people? Who are the people that John Keaveney is talking about? Some of you are probably aware of this study that looked at mortality across, this is the level of deprivation in England and Wales in terms of the mortality rate. So it's about double from the richest to the poorest deprived area. But when you add in this group of people who are homeless, out of prison, injecting drug users, you have what's described as this cliff edge of inequity. These people must be the extremely poor. These people are the excluded, hardest to reach people. So there's big issues around these sorts of groups as well. John Keaveney worked on needs assessment issues in Ireland, on getting people to work with marginalised groups, with travellers, with others as well. We have a framework, we have a policy in Ireland, the Healthy Ireland Framework for Health and Wellbeing, that actually has addressing and reducing health inequalities as a core policy goal of the Department of Health and of the Health Service. But we have big gaps between the richest and the poorest, or the most deprived and the least deprived. So we've had great success on tobacco, but the success is at the least deprived end of the population. So we're not reaching the extremely poor here. Recently, most of you will probably be aware of the publication of this report a fortnight ago, looking at the private activity in public hospitals. You're all aware of waiting times in Ireland. There's this huge delay. If you're a public patient, you're going to be waiting a long time for some things. If you're a private patient, you're not going to. So we have structural inequalities and inequities built in. A lot of you will have seen these sorts of slides before about what's equal and what's equity and what's equality. So we talk about equality as everyone having the same supports. Doesn't necessarily mean that it's fair. We can talk about equity as everybody getting the support that they need. The Commission on Social Determinants of Health talks about proportionate universalism, to ensure that the people who need more get something more. But really, ultimately, we need to be talking about justice. We need to be talking about getting rid of the structural barriers and the causes of inequity. And I think that's sort of underpinning the whole thing about people who are marginalised, people who are stigmatised. But this is described as, this is a really hard nut to crack. It's not going to happen from national policy. It has to have community involved. People have to be involved in decisions around this as well. You're all aware of the language of rights, and that health is seen as a human right for everyone at every age. And you're probably all aware of the language of the right to health. A lot of it focuses on health services, on access and availability and accessibility and quality of health services. But it also means action on all those other determinants of health, all the things that matter, where people live and how people, where people live, how they go to school, what they eat, and all of those other things as well. So, rights is really important. Rights is a legal instrument. It's something that can be used to challenge. How many people know about the public sector duty in Ireland? This audience is not representative, I guess. But so some of you do. Some of you do know. So, there is actually a legal instrument in Ireland. The Irish Human Rights and Equality Commission Act imposes a statutory obligation on public bodies to do these things. Public bodies are supposed to eliminate discrimination. They're supposed to promote equality of opportunity and treatment for their staff and the people who use them. And they're supposed to protect the human rights of staff and the people who use services. And that's health services, education, housing, everything else. Some parts of the public service in Ireland have taken this on. The health service is coming late to it, but it's slowly starting to. But this is something that we can use to make people accountable. There is actually a legal obligation for things to happen. There's a legal obligation. The law says that the way this is supposed to work is that bodies are supposed to assess what they're doing around rights and equality. They're supposed to set out how they're going to address it in their strategies and policies, and they're supposed to report on it. So the health service, there's a big challenge to get this done, but it is starting to happen. The safety net, people were outside, we talk about inclusion health. The people who are most excluded, some of the inclusion health focuses on homeless people or injecting drug users or others. But again, tied into that is a whole thing about assessing and measuring and addressing. So we don't have ways of measuring all of these things in Ireland and in many other parts of the world. And if you don't measure it, if it's not counted, is it going to count? Somebody mentioned this morning about child registration. I was telling somebody at lunchtime, my oldest child was born in Zambia. She was born on a Saturday, and Monday morning I went in to register her so that I could get her on the passport. And the guy in the office said to me, "Why would you register her?" I said, I want to get her on the passport. He said, come back when she's going to school. I said, no, this is serious. And then he said, and it's going to cost so much, whatever, I need to get it done. She might die. But counting, if you don't count, can you be counted? There's so many other things that we could talk about. We need to talk about sustainability. We need to talk about sustainable health services and the ways that things happen in healthcare. Health is not just about healthcare, but we need to look at in the healthcare sector itself. We need to look at sustainability for ourselves. We need to learn from other groups. We need to learn. The language of climate justice and the language of we could learn a lot in terms of health justice. Climate is becoming much more mainstreamed in Ireland. We're hearing more about it. Mary Robinson was a good friend to the forum in the early years. She was the patron, and the first few conferences she opened and that kind of thing for us. We've heard from Irish Aid already this morning. Irish Aid has a brilliant new policy document. There's big focus on SDGs and on the equality and rights, climate and other things. And you've probably seen in the answer to the parliamentary question about the future funding of Irish Aid, there's projected to be an enormous expenditure. We're supposed to hit the 0.7% by 2030, but that's an enormous amount of funding. So Ireland's aid efforts are going to change dramatically. And health is part of that. The determinants of health are influenced hugely by that. Just in the context of talking about communities and contacting communities, we've had a lot of people come to the forum over the years from the People's Health Movement. We've had a range of different people. The People's Health Movement is this big global network that goes from activists, from civil society organisations and academic institutions. We've been asked about joining it from time to time. There's a People's Health Movement charter for how things could. I know there's a couple of people here who are signed up to the People's Health Movement, but I guess it's something that we need to consider. for the future in terms of a way of linking in with other community groups and other activists. And I have to mention David Sanders in this, who's the chair of it, who died about 2 weeks ago, who talked at the forum in 2005 and in the College of Physicians the following year, and has been at various other times here. And while I mention him, I should mention other people who've been involved in the forum who've died, like Noel Murphy from Maynooth and Fiona Larkin, and a range of other people who've been involved who have died as well. David and the People's Health Movement pushed the idea of the struggle for health justice. David's book, The Struggle for Health, I heard him when I was doing a course in tropical medicine in Liverpool years ago. He came and talked about this book, and it was just life-changing, just to hear the descriptions of how things could be done differently. And he's also been one of the authors of the Global Health Watch. I don't know if some of you know this. It's the Alternative World Health Report that's produced by the People's Health Movement every few years. Rory's actually contributed to it, haven't you, in the past? Your name's in one of them. One of the big messages, just in terms of communities and community activism, the last thing that David Sanders published was in The Lancet 2 weeks ago, the week before he died, and it was about primary health care, revisiting the idea of when primary health care was described in 1978 in Almaty, it was about universal accessibility, about comprehensive care, about community involvement and self-reliance, about intersectoral action, about appropriate technology. You've all heard this before. It was revisited in Astana then at the end of last year, the Declaration of Astana, to push primary health care, but the stress on the comprehensiveness and on community involvement and on the determinants of health has been watered down a little bit. So we need to think about what that means. There's also the conference that's on, or the meeting in the UN the week after next about universal health coverage. It's not universal health care. It's around, is it focusing primarily on financial protection? So that message that David Sanders had recently was about primary health care should be the umbrella overseeing all of this, not just something in the corner around it or something that's underpinning it. So we need to think about how the forum links in with other forums and other groups and other networks, with other networks like the People's Health Movement and other groups. And we need to think, there's people talk about the energy, the energy of people in the room. There's so many young people who want to be involved in this. We need to enable and find ways to do that. And we also need to ensure that there are ways for people to be educated, to get involved in research, to get involved in advocacy, and not to be afraid to do those things, and not to be afraid to step off the treadmill of careers and all of that kind of thing. I think a lot of people who've worked in different parts of the world, none of us have a clear pathway. We didn't do it by the book. So I don't think people should be too afraid to step off the treadmill if they want to. I'll just leave you with just a last couple of quotes that will lead into, again, back to what John Keaveney had said in terms of what we need to be doing here. These problems are not going away, and they're being presented as though, and sometimes, that the world is getting better. And sure, the world is getting better for a lot of people, but there are some problems that are not getting better. And again, just going back to the Commission on Social Determinants of Health, these are the bottom lines of what we maybe need to be doing.